Good morning, everybody. Jamie asked me to balance hope and fear about healthcare transformation and to go through all of the dynamics of disruption in 20 minutes. No problem. So anyway, that's what I'm going to try and do. Tribute to Marvin Gaye. There are people old enough in the room to remember who Marvin Gaye is. He had a song, Tell Me What's Going On. In the first week in December, there were 5 major transactions. I'm sure you've heard. CVS announced it was acquiring Aetna. United announced it was acquiring DaVita Healthcare Partners. There are a couple of big health system mergers, and Humana announced that they were acquiring Kindred's home care and hospice assets. And then the hits just kept on coming earlier this year. We saw that Cigna acquired Express Scripts. There was the Amazon announcement. It's just been one big major transaction after another. And I'm a markets guy. I wrote a book called Markets versus Medicine. Tom, you got to wave it because I gave my one copy to him earlier today. But these are major market signals from established players basically saying our existing business model isn't sustainable, so we need to do something different. And there's this feeling of foreboding. For whatever reason, the right side of my slides aren't coming up, but there's this feeling of foreboding that's similar to 1963. People, when they talk about the 60s, discuss the period from the Kennedy assassination to Nixon's resignation. So November 1963 to August 1974, where the country went through this massive cultural change to the point where people in the early 60s with short hair and engineer glasses couldn't recognize the hippie communes at the end of the year, just 10 years later. So Bob Dylan wrote a song in October 1963 called The Times They Are Changing. Everybody know that song? Okay. The first day he performed it was November 23rd, so it was the day after the Kennedy assassination. And he wasn't sure whether he should perform it, but his whole concert was built around that song. So he decided to go ahead with it, and the audience just erupted. People were crying. There were, huge applause afterward. And he was talking to his biographer several years later about this, and he said, I don't know why I wrote the song. I don't know why the people were reacting to it the way they were. It was just incredible, but there was just this sense that we are on the cusp of incredible change in the country, and often artists are the harbingers of major social change. And so that's kind of this period we're in right now. It's called the eve. I'm calling it the eve of destruction. And David Cordani, the CEO of Cigna, kind of captured it in a conference earlier this year. The press for affordability, the thrust of transparency, the demands from consumers for ever more personalizations, are ever-present forces driving more positive change than negative. I think there's a big quantum leap about to aspire. So, as Amy said, don't get comfortable. This train is picking up steam, and you know what? It needs to. This is a relatively old article from Health Affairs, and it looked at mortality at Mass General Hospital, one of the nation's great hospitals, against adjusted cost per patient discharge. And I put the two graphs superimposed them on one another. So you can see, one, you didn't want to be a patient in the early 1800s, right? The up and down mortality. But then as medicine modernized, death rates came down. But on an inflation-adjusted basis, look at cost, which kind of stayed pretty straight until 1965. What happened in 1965? Yeah, passage of Medicare and Medicaid. Then it's hockey stick up to the right. So in order to get Medicare and Medicaid legislation passed, President Johnson, no relation, yeah, really, no relation. President Johnson agreed to a couple of things. The first was what was called cost plus reimbursement, that we basically pay for treatment plus a margin. And then the second was, and this isn't as well understood, no medical interference, no governmental interference in medical decision making. They also agreed that Blue Cross would administer the program. But those things built a big enough loophole that you could not only drive a truck through, you could drive every truck in the world through. So we built in a system basically of supply-driven demand to the point where if a doctor does something, they get paid for it. There was an economist at UCLA, Milton Romer, who at the time said, in the presence of third-party reimbursement, supply creates its own demand. So that's exactly what we have in healthcare. It's this artificial economic model where supply creates its own demand. And oh, by the way, if you're going to pay for more stuff, do you think you'll get more stuff? Jens and I were talking about the Hospital for Special Surgery in New York this morning. I forget how many MRIs did they have? It was 12 MRIs for a 200-bed hospital. You know, when you pay for more stuff, you get more stuff. So I've been trying to figure out why the system has been so resistant to change. So Donald Berwick and Andrew Hackbarth in 2012 published this seminal article about waste in healthcare. And they concluded, it was a really rigorous analysis, they concluded that somewhere between 21 and 47% of healthcare spending is waste. And they identified it in 6 categories. The 6 categories were things like overtreatment, fraud and abuse, excessive administrative costs, and so on. And their recommendation was, now that we've identified these 6 areas of waste, let's work incrementally on them to get them down to the rate of inflation so that the system can be sustainable. So that was based on 2011 numbers. $2.7 trillion of healthcare expenditure. 2016, $3.3 trillion of healthcare expenditure. The healthcare economy in the United States is almost as big as Germany's right now. It'll pass Germany sometime in the next couple of years. Germany's the 4th largest economy in the world. Our healthcare expenditure is equal to the 4th largest economy in the world. So 2.7 trillion to 3.3 trillion, and there's been virtually no change in practice patterns. If anything, the percentage of waste has probably increased a little bit because of all the nonsense the pharmaceutical companies are doing. So I've started to look at healthcare as a chronic disease, and essentially, you know, got pathologies and root causes, and as with any chronic disease, unless you address the root causes, you're never going to cure the disease. And there are 3 pathologies and then 3 root causes, and I'll cover them pretty quickly. The first is revenue optimization. Healthcare is built to optimize revenue. So when you're in a supply-driven demand situation, the objective is to get paid. And then the second is monopoly and monopsony pricing, so production control and purchasing control. So this idea of monopsony control came home to me last year when Blue Cross Blue Shield actively fought against the merger of Advocate and North Shore. Advocate, largest health system in Illinois. North Shore, a very nice system, much smaller on the North Shore. And Blue Cross publicly was neutral. Behind the scenes, they were saying to Advocate they favored it, but they actually created this black ops group that was doing everything it could do to torpedo the merger. And it didn't make any sense to me because Blue Cross Blue Shield and Advocate had a long history of doing things together. I couldn't believe they cared about, you know, over-concentration in one zip code on the North Shore, which is why the government was suing to block the merger. So I called up a friend of mine at Advocate and said, what's going on? And he said, you know what? I think they're afraid we're going to become an insurance company. And that's when the light went off. So they have 75% market share in metropolitan Chicago area. They want to keep it. They're going to do everything they can to keep it. They have pricing control to the point where they're willing to torpedo a really valued relationship to continue it. So there are other markets where providers, like in Columbus, Ohio, have production control. No insurer has more than 25% market share, and they are pushing through $5 billion of new capital expenses for acute facilities for a population of 2 million people. That's a lot of appendectomies to pay for. So what we have in this country are all of these pockets of monopoly and monopsony pricing power, and if you've got it, you don't want to give it up. So if those are the diseases, the pathologies, what's driving it? The root causes are complex payment formularies. I don't know, if some of you are in school, go look how Medicare figures out how to pay for something. It's a formula this long, and there's only a little bit of outcome data at the end. And you know what? The marketplace is always smarter than the central planners. Everything you need to know about hospitals is they've got robust revenue cycle capabilities and at best rudimentary cost accounting capabilities. What Amy is trying to do at Providence is radical, actually understanding costs in relationship to outcomes. And then the two other root causes, unbalanced regulation and government capture. The fact we regulate hospitals at the federal level, insurance companies at the state level, you get this, nobody's looking at the whole ecosystem. But even worse than that, because of this unholy trinity of Congress, industry and industry groups, and bureaucracy, where they're all helping one another to the detriment of society as a whole, we get regulation that's too soft. They support politicians who support them. People move back and forth between industry and government. And that reflects itself in the fact that healthcare, when you look at lobbying budgets, is 5 of the top 10. Pharmaceutical industry is almost twice as big as the next biggest. So I don't think, with all due respect to Berwick and Hackbarth, this is not an incremental problem. We need a radical solution to this. And I believe ultimately we will only fix healthcare delivery. We'll only change it if we change the way we pay for it, which the marketplace is working on. But until and unless we start to attack regulation and government capture, we're just not going to break this iron triangle. And actually yesterday you may have seen that Secretary Azar is attacking Part B pharmaceutical spending. That is a direct shot at kind of this hospital or healthcare industrial complex, particularly on the physician reimbursement for high-cost drugs, and then ultimately the pharmaceutical companies. So that's going to be a battle. I'd encourage you all to watch that. So demand-driven change, superhero results, what I was just talking about. Until we change the way we buy healthcare, we're not going to change the way we deliver healthcare. But that's starting to happen. Medicare Advantage is a form of full risk contracting, not a perfect program, but 1/3 of Medicare beneficiaries are in Medicare Advantage right now. And when you look at the baby boomers demographics, people like me in the next 5 years are going to start hitting 65 in record numbers. So Medicare Advantage is going to go up dramatically. And so in markets where Medicare Advantage is more than 50% of the Medicare population, Twin Cities, Portland, Oregon, right here, Orange County, California, you really start to see vertical integration between payers and providers to come to terms with how do we manage the care for distinct populations. And so we're starting to see that. So demand-driven change, superhero results. And what I just was talking about, this is the Gartner hype cycle together with Jeffrey Moore's idea of innovation, how it goes through innovators, early adapters, and then there's this chasm, which is the trough of disillusionment, where a lot of innovation goes to fail. And the reason for that is this next category of buyers, the early majority, which Jeffrey Moore called pragmatists, have to believe the innovation is going to occur before they buy in. And if they fundamentally don't believe that, they don't buy in. Now, interestingly, I believe what I talked about at the very beginning, these major signals from major players, is an evidence that the early majority is starting to speak. So this idea that we will get real value-driven change through full risk contracting on the episodic level through bundles, full risk bundles with guarantees, what Amy was describing. By the way, right here, this organization probably has a better sense of its costs than just about any orthopedic institute in the country or in the world. So if they, if I'm HOI and the country says we're going to full risk bundles, I want to say to, to Bob and Jamie, bring it on. We can do that, and we should want that for the country. So that's kind of what's happening. So when you think about the post-reform marketplace, I put together a kind of a classic consultant 2x2 grid here with care duration on the x-axis and care uncertainty on the y-axis. And the interesting thing is if you've got an episodic care incident and you have a very high probability of a positive outcome, that's a commodity. That's retail care. That is the type of thing where you need high volume and low margins in order to succeed. And guess what? Like 70% of what happens in healthcare is commodity care. So you go up a box here, you get specialty care, so like a heart transplant. And my guess is with those, we're going to start to see more and more focused factories, because we know that if you have high volume and routine procedures, you get better, quality gets better, costs go down. You go to the upper right, complex care. This is the real tough stuff. The solution shop cases, you need real expertise. It's trial and error. This is what the Mayo Clinic and Cleveland Clinic are meant for. The question is, how many of these types of organizations do we really need? We certainly don't need 6 of them in Chicago, where I live, and they all aspire to be the place that does this advanced care. And then you have the non-acute chronic care. And the scary thing for providers is this is all moving down. So joint replacements used to be prototype of specialty care, but if they haven't yet crossed into commodity care, it's very close to getting there. So what the marketplace is doing is segmenting, and they're attacking where they have strength. There are record amounts of private equity and venture funding flowing into digital tech and services, less so to device and pharma. And what that tells you is the marketplace believes the real play over the next 5 to 10 years is fundamentally restructuring the way we organize and deliver healthcare. So we're getting this really strong bottom-up market-driven push to try to improve the way we deliver care. The challenge for places like Prov St. Joe's and other large health systems is they've tried to be all things to all people and end up not being really good at anything necessarily. So, for organizations to determine how they what they can do best, and then to play in the marketplace and be relevant as we shift over to this full risk contracting is going to be a real challenge. Great quote from Bill Gates. Everybody always overestimates the amount of change in the first 2 years and then underestimates it in the next 10. So if you want to know who the disruptors are, they're companies like these enhanced primary care companies, Oak Street, Iora, and so on, that are really getting to know their customers and move forward. Retail facilities, if you don't think CVS is going to be in the business of managing chronic disease in 5 to 10 years in a major way, I don't know what you're smoking. The focused factories, so on and so forth. So to me, the way it's funny, now I've got a few bullet points there on the right. The way this is kind of breaking out big picture, I believe, is we are seeing this furious two-front battle. The first one is for members, so you can look at the CVS Aetna as a way to kind of get control of members. Walmart, rumored to be talking to Humana, the same kind of thing. And then the idea of clinical precision, right care, right time, right place, right price. And that to me is how the marketplace is segmenting this. And ultimately, it's going to be who controls the members and who delivers the care in the best way and how do they come together that I think will shape how we deliver care. Oh, by the way, I don't think our goal as Americans should be to be as good as Canada. I think we ought to be better. And if we can actually unleash the American innovation machine on these two streams, that's the way to get there. But we have to get the incentives right, and we got to get the government thinking about it the right way. So Amy gave me a plug. We wrote an article called Platforming Healthcare Together that was pretty widely distributed. It was and got a lot of press. And sort of the idea was that historically, when we've been in the artificial supply-driven demand, it made sense for health companies to own and control everything. But as we shift to her definitions of value, which have everything to do with cost and outcome, the idea that you need to own everything is ridiculous. You need to figure out, what am I good at? What do I really want to own? Where do I partner? Where do I outsource? And drive your activity toward that. And that's what Microsoft, Amazon, all these other companies do. And when you realize that you're now engaging with customers, brand, price, and customer experience are the differentiators. So last slide, and I'll just be a minute over, but we're in this situation where healthcare is moving from the old math to the new math. The old math was revenues are flexible, you can always get paid more money, that's why there's revenue cycle. Expenses are less important, they're usually baked into the formula, and the difference is margin. The managerial orientation is on getting paid. The new math, and remember I said 70+% of healthcare is commodity. Revenues are inelastic or largely fixed. Managing expenses is exceptionally important. The difference is profit or loss, and creating value should be or becomes managerial orientation. So the world's going to belong to the companies that can practice the new math, consistently connect with consumers, and so on. And I love this quote from Einstein that, when you're playing a new game, you got to learn the rules of the new game and play it better than anybody else. So that's the new game. So 21 minutes. I did okay. All right. Yeah.